In this lecture, we're going to examine another type of diabetes mellitus referred to as type 2. And recall that 9 out of 10 Canadians afflicted with diabetes mellitus have type 2 diabetes mellitus. And this has been referred to as non-insulin dependent diabetes mellitus. It's also been referred to as adult onset diabetes mellitus, but those terms have since been replaced with type 2. And one of the reasons for this is because of the trend that has been observed in the last 20 to 30 years. And statistics suggest that 1 out of every 3 children born in this century will likely be diagnosed with type 2 diabetes mellitus in their lifetime. And this is in Canada and the United States. Now, the most affected in Canada are First Nations children, and cases are seen as early as 8 years old, and this occurs as a comorbidity with obesity. Now, the assessment and diagnosis of type 2 diabetes mellitus is the same as that as type 1, in that the individual suspected of having type 2 is assessed for their level of blood glucose. So hyperglycemia is definitely a sign of type 2 diabetes mellitus. So it follows the same criteria. Now, in the case of type 2, physiologically, this is a very different situation. Now, in people afflicted with type 2, their own supply, their physiological manufacturing of insulin from the pancreas is initially okay. So they're able to produce enough insulin. The issue in the type 2 case is that the cells that would respond to insulin, those are liver cells and skeletal muscle cells, become what's called insulin resistant. So as much as insulin is present, the cells are just simply not responsive to that insulin being produced. Now, the two effective ways, not the only ways, but two effective ways in dealing with type 2 diabetes mellitus and assisting with management includes the eating pattern and reducing the intake of simple carbohydrates. Those are essentially sugars, does help to prevent the sharp spikes in glucose and insulin. And physical activity, chronic physical activity, has been shown to improve tissue glucose uptake by activating the enzymes that would pull glucose out of the cardiovascular system. So in terms of the risk factors, just as we saw with type 1 diabetes mellitus, type 2 does have a genetic predisposition with a family history. People that are in the overweight or obese category are statistically at a greater risk of developing type 2 diabetes, and living a sedentary type of lifestyle. So people that do not engage for whatever reason in physical activity chronically are at a statistically greater risk of developing type 2. A low level of what's often referred to as good cholesterol, high density lipoproteins, or an abnormally high level of triglycerides, which are the storage form of fatty acids, are also seen as a risk factor. Women that develop gestational diabetes during a pregnancy, and we'll detail that here as well in this lecture, are at a statistically greater risk of developing type 2 diabetes mellitus following the birth of the child. Syndrome X is a particular syndrome that's referred to as metabolic syndrome. And this is a very general condition that is characterized by what's called hyperinsulinemia, which is a chronically high level of insulin in the blood, hypertension or high blood pressure, and insulin resistance. So despite the fact that individuals with syndrome X or metabolic syndrome are secreting an abnormally high level of insulin, liver cells and muscle cells are just simply not sensitive to that insulin. A significant correlate to, and again, this is a statistical correlation to the development of syndrome X is body weight, and a person that has been diagnosed of potentially having metabolic syndrome are most likely to be in a pre-diabetic stage. The last type of diabetes mellitus we'll touch on here is gestational diabetes mellitus, which is a result of a pregnancy. And this usually occurs beyond the first trimester of pregnancy. And it's estimated that approximately 4% of all pregnancies result in the development of diabetes mellitus. And there is a higher incidence of women eventually becoming pre-diabetic, or women that are pre-diabetic prior to pregnancy are at a statistically greater risk of developing full diabetes mellitus into the pregnancy. And there are many theories of why this would occur. One of the causes is that with a pregnancy, there would be an increase in cortisol secretion. Cortisol is a hormone secreted by the adrenal gland that, when secreted chronically, has been found to contribute to an increase in insulin resistance. So it doesn't affect the ability of the pancreas to produce insulin, but cortisol is thought to reduce the sensitivity that the tissues have for insulin. As progesterone levels are high, studies show that progesterone does have an inhibitory effect on beta cells. It doesn't necessarily mean that it will cause the beta cell to decrease insulin secretion, but isolated studies do show progesterone does have that inhibitory effect in isolation. Human placental lactogen is a hormone that is produced by the placenta, and this has the effect of stimulating a breakdown of stored fat in the mother. And it's this particular hormone has been implicated in insulin resistance. So some of the risk factors in the potential for developing gestational diabetes mellitus is, first of all, a woman that has existing diabetes mellitus prior to pregnancy. As we saw with type 1 and type 2, a family history. So there is a genetic, appears to be some genetic factor involved with this. And statistically, an excess amount of body fat, so being in the overweight or obese category prior to pregnancy, is seen as a statistical risk factor, as does age. And some of the complications that can result from gestational diabetes mellitus is similar to what was observed with type 1 and type 2 in earlier lectures, in that there is a tendency of having high blood pressure. And because the growing fetus uses glucose almost exclusively as a fuel source, it would contribute to macrosomia, which is a large birth weight. And so this does pose some additional risks, health risks during the delivery. In severe or uncontrollable cases of gestational diabetes mellitus, this can result in jaundice of the newborn, as well as potential brain and growth development in the newborn. And this might be due to a reactive hypoglycemia. Now, this seems a little bit different than how we define gestational as a state of hyperglycemia. But what we're looking at here is a reactive hypoglycemia if a situation during a pregnancy arises where there's an excessive secretion of insulin. So as insulin spikes to a high level, if that were to happen, that would cause blood glucose levels to drop very quickly and to a large amount that could potentially impact the cells and the growth of the cells in the newborn. In terms of of management of gestational diabetes mellitus, the typical approach, particularly with type 2 diabetes mellitus, is often taken. And so, and from a dietary perspective, smaller, more frequent meals and meals that are mixed. So, not meals that contain just carbohydrates, but mixing carbohydrates with protein and lipids in one sitting. Focusing on complex carbohydrates, so carbohydrate food sources that contain carbohydrates coming from starch and dietary fiber will also help to regulate a management of blood glucose. A reasonable level of physical activity to ensure that the muscle cells are activated routinely so as to activate the enzymes that would draw glucose into the cell and make those cells sensitive to insulin. Daily monitoring of blood glucose levels is essentially required in this case. And post-birth monitoring of the mother is also highly recommended and is often routine because statistically, a woman that develops gestational diabetes mellitus is at a statistically greater risk of developing type 2 diabetes mellitus later in life. In the vast majority of cases, gestational diabetes mellitus alleviates almost immediately soon after birth. But monitoring the mother following the birth is going to be an important element to ensure that the management, self-management, physiological management of blood glucose levels is maintained. So this ends our final lecture on part 1 of diabetes mellitus.